Welcome to Inside Aesthetics, the world's leading podcast for injectors and cosmetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor based in Sydney, and I'm joined by my co-host and good friend David Segal, an entrepreneur and an aesthetic business mentor. Each episode of IA showcases unfiltered conversations with guests from around the world. In a sometimes disjointed industry, IA aims to help educate and connect our global community to raise the bar for both our businesses and our patients.
To further support and educate our listeners, we offer a range of additional resources under our IA Patreon subscription service. This caters for injectors and business owners of all levels and includes interactive live Zoom sessions, webinars, hints and tip videos, private chat groups, and exciting future content to come. To subscribe to IA Patreon, head to www.insideaesthetics.com/Patreon or click the link in our podcast description. You should seek medical advice before undergoing any treatment or procedure, and these podcasts do not replace a professional and bespoke consultation.
It's chapter 6 of the Tox Talks. I like these ones. I'm excited.
Yeah, well, last one got an amazing response, Dr. Michael Caine.
Well, if it didn't, I'd be worried. It's like the god or the king of tox. But today we're going on a different angle. We've recently had a new toxin released here in Australia and globally just before we got it in Australia. So what's it called?
Letybo.
Letybo. But it's not called Letybo in other countries.
No,
so
it's not.
Why don't we welcome our guest and then we can get into all of the nomenclature of this new toxin. Good evening, good morning, Professor Haq, all the way from the UK. How are you, Syed?
Yeah, I'm good. It's good morning because I had to get my son up and get him ready for nursery. So that was a bit manic. So mornings always start the same way, Monday to Friday. So yeah. I'm orientated in time, space, and place at the moment. So glad to speak to you guys.
Well, we appreciate you coming.
To the discussion.
Yeah, absolutely. Now, why don't you, I've not had the pleasure of meeting you. David certainly hasn't met you. So why don't you introduce yourself to our listeners? Tell us about, obviously what your day-to-day job is, what maybe your background is, and who do you represent?
So my name is Professor Syed Haq. My background is originally from Guy's Hospital in London. So our sister school is Johns Hopkins in the United States. I trained at some of the major institutions in the UK from the Hammersmith, Brompton, and Guy's hospitals. Then spent time at Imperial College. I was a Medical Research Council clinical training fellow. And then got an opportunity as a registrar to go to the United States and study and work at Harvard Medical School and Massachusetts General Hospital. And my late but very dear friend and mentor, Professor Thomas Force, was the guy that really guided me and opened my eyes to how we should view science and how it applies to the clinical scenario. And in that time, I collaborated and did work with the cutaneous biology research program there. So that got me really interested in skin aging and inflammation. I published a lot of papers. I was an award-winning scientist. I was AstraZeneca Young Scientist of the Year in New England and various other things. And then I decided to come back to the United Kingdom. And my love of aging, aesthetic medicine led me to chair a number of meetings in the UK on aging, and gerontology. And from there, I was also headhunted and worked with 2 biopharmaceutical companies. So I had a good science core as well. I didn't give up my clinical practice, and I continued to build that both in the United Kingdom and in Northern Ireland. And that's where I met my wife, Alexandra. I was actually giving an anatomy lecture at Croke Park, famous for rugby and Gaelic football. And then I just sort of continued both on the biopharmaceutical clinical side and started to also look more deeply at the basis of what we're doing with our patients, not just simply seeing what's on the label, but trying to understand how we can take this frontier further. I was formerly in the NHS, no longer privately practicing. And I found there were a lot of constraints in the NHS, which I didn't find in the private sector. And I found that many of my colleagues were really cutting edge in their approach And we're changing things so dynamically that some of their important observations were being adopted into mainstream medicine. And that was really gratifying. So I've continued in that. I've worked in part with Rothschilds and PwC in the past on various projects. And where I am today is apart from overseeing a number of clinical trials and being a co-PI on several trials, I've published a lot as high a profile as Nature Medicine. But I've also tried to develop other areas of aging therapeutics. So I've developed a drug that we will hopefully aim to be in clinical trials by the end of the year, which will be focusing on the aging process and trying to uncouple age-related disorders from aging, as we see it. I'm currently a key opinion leader for a number of major groups, from Hugel Aesthetics, Chroma, Pharma, as well as Allergan, part of AbbVie, and Galderma.
Wow. Fantastic. What a CV.
Wow. That's
we've struck gold, David.
Very extensive, impressive history.
Yeah. Now, why don't we actually define what we mean by a KOL? And I understand that you sit on the advisory boards for at least one of those companies. So basically, what do you do? I know because I act in that capacity just for Allergan Aesthetics. But what does it mean to the listeners who don't really understand that role?
The key opinion leader, I mean, in the more recent times, we're finding that lots of people are calling themselves key opinion leaders when they're really, and one of my colleagues put it perfectly, and he said, if you want to be a key opinion leader, what contribution have you made to your discipline here in aesthetics? Have you published anything that's novel or could better educate your peers? And have you made any major strides in that in terms of clinical observations, case studies, and publications? And I think that really tells you what a key opinion leader should be in terms of their background, highly experienced and well-versed in not just the product that they're talking about, but others, and be able to compare and contrast them. So I've sat on and continue to sit on a number of advisory boards, global advisory boards. For example, for Allergan, I'm going to be presenting and doing some work on neocollagenesis. With Ipsen, I was sitting on two different boards, one on their new innovation products, as well as their clinical trial development program. And then same, one would say, of Galderma and of Chroma more recently, and Hugel, working with Letybo and looking at the clinical rollout of that, as well as polynucleotide treatments, which are the rage, and doing some amazing things with patients now in a safe manner, but with reproducible and clinically meaningful results. So with all of what I do, I analyze what's presented to me, critique it, determine whether or not the results that are being reported to me are absolute, or could one look at them differently? And I'm always asking the question, I won't be satisfied with just what's presented to me, but foremost and uppermost in my mind is it safe?
Yeah.
And because patients come to see one and they're spending their hard-earned savings and they want something that really does work. And with that patient-doctor relationship, that's established over time, but that can only really be fortified if what you're doing on an advisory board capacity is transferring that information to the patient in a way that really does transfer properly. And the patients appreciate it, and you can provide them with new innovations and maybe alternative ways of treating some of the steadfast things that we see day to day.
Yeah.
Such a good point.
Yeah. So when it comes to toxins, we've had them for quite a number of years, probably close to 20 years now, maybe potentially more.
Yeah.
And for the longest time, there was really, particularly in Australia here, only two players on the market. And in the last few years, we've seen a number of new products emerge, a lot of off-label treatments start to develop, people starting to almost fall in love again with toxins and finding out different ways they can use it to sort of not only chase lines and wrinkles, but to focus on the shape of the face and the lower face in particular. So keen to get your thoughts on how that journey has sort of transpired and the sort of transition from very rudimentary applications to more advanced treatments and where we're in now, which is a plethora of products entering the market.
Yeah, I mean, the origins of toxins go back centuries, but in a clinical aesthetic scenario, as you're right, David, it's been here for about 20 plus years with the advent of Botulinum Toxin firstly, and then Botulinum with the different descriptive labels on those. And originally, they were being used in medical terms for the treatment of dystonias torticollis and as well as blepharospasm and strabismus. And then, from the observations of gene analysis or others, with the likes of Alan Scott, they realized that there was a potential aesthetic implication here with a reduction of the lateral canthal lines that they were observing. And originally, when they presented this work, they were poo-pooed and ridiculed to some extent. And I remember Gene saying that people were saying, well, why don't you have a better use for your medical qualifications than looking at aesthetic use of a neurotoxin? And we've come full circle with that, with our realization that the use of neurotoxins have a fundamental psychological well-being impact on patients with a reduction in the social psychological burden that they may be facing, apart from the positive aesthetic impact that they're also achieving. So if we look at all of the different types of toxin, yes, there has been a new evolution. And the evolution has really been driven by, I would say, trying to innovate the manufacturing and purification process to try and obtain something that is possibly better or as good as, possibly cheaper, safe, and predictable. And different companies have looked at that in different ways from their manufacturing protocol. The gold standard, and they cover 80% of the global aesthetic neurotoxin market, would be Botulinum Toxin, made by Allergan, a company of AbbVie. And then the second and third would be the likes of Botulax, made by Hugel Aesthetics and Kushan in South Korea. I believe their principal ingredient is Letibotulinum Toxin. They're the number one in South Korea, and they're the second largest globally. Why that's an important statistic to understand is South Korea, in particular, produce about half of all the world's neurotoxins. And that's a testament to their quality assurance and quality control, but also their innovation. And they have, and this is where there is room for other toxins within the market based on what type of target population you're particularly looking at, what type of effect you're trying to achieve. Frozen, formerly, now more natural, longer lasting toxins, earlier onset toxins. In the future, there will be what I would define as hybrid toxins, which will last very long or shorter. There's a liquid toxin in Illusians. So all of them are there for different reasons. Ultimately, they're trying to maximize efficacy and safety profiles for the patient. And they're trying to achieve this through, as I said, different manufacturing protocols, whether they're freeze drying, vacuum drying, whether they're utilizing a 900 kilodalton protein complex or a light heavy chain complex in the form of incobotulinum, which is devoid of complexing protein. And you can have your viewpoint based on the clinical data, the scientific data that's emerged. But ultimately, whatever toxin you choose to use on your patients and your patients are wanting, it has to be clinically evidence-based, and there has to be substantive clinical evidence. And the major players in that, in terms of clinical trials and their investments, have been Allergan, Ipsen, Hugel, and Merz. And then you come through other neurotoxin producers who have fewer clinical trials, but they're gathering momentum and pace, such as prabotulinum and Daxi.
Yeah. Now, you mentioned a brand called Botulax, which, to be clear to the listeners, is basically the same as Letybo. Letybo is sort of a new branded name. Is that correct?
Yeah, I mean, when I look at these things and people talk about, well, it's Letibotulinum toxin, I said, yes, absolutely, it is Letibotulinum toxin. But irrespective of how you look at a toxin, whether it's ONA, ABO, so ABO can be in the form of Dysport or Azalure, and you've got Botulax or Letybo, is the manufacturing line.
Yeah.
And that goes through a process of bioreactor fermentation, production, and then acid precipitation and purification. And then some of them will choose either a freeze-dried process or vacuum-dried process. When you look at Botulax and Letybo, they're produced in different vial forms, so either a 100-unit or a 50-unit vial. And people say to me that doesn't make a difference. And I say, well, it may make a difference because you've got protein all in one vial, or it may not. And that's when I ask the question to manufacturers to tell me, is there a difference? And then I look at the clinical trial data. And if you imagine, if you put a lot of protein into one unit or one vial, or you've got a lot less, does that impact the long-term stability of the product or not? I'm not saying it does, but they have the experimental evidence to determine that. And I've gone through this whole manufacturing process with the drug that I'm developing, where you've got 30 scientists on the line, and they talk about pH variation, and we're talking about 0.1 or 0.2, what excipients you're using, how much you put into a vial. All of that will have a determining impact on the amount of active neurotoxin. If you compare all of the neurotoxins that we've mentioned, the light chain, which targets SNAP25, the synaptosomal associated 25 kilodalton protein target, from the paper published by, it was actually Walsh, that showed that, he was the head PI, that the activity, that's the enzymatic activity of the light chain, was equivalent in all. There's no difference.
Right.
So therefore, the manufacturing protocol then will define, as well as the presence of certain excipients, of how the patient reacts.
Yeah. I guess, I mean, that was fascinating, by the way. I'd never really thought about it like that. But I guess the take-home point for your average listener is Letybo, or Botulax, if you want to call it that, has been around for a reasonable amount of time. I think since 2009 or something.
Yeah, 13, 14 years.
Yeah.
25 million vials using Letybo. That gives me reassurance, as opposed to something that's been used maybe for a shorter period of time with far fewer patients. And what's also important when one looks at whether it's Letybo, Botulax, or others is, well, in the clinical trials, what sort of age group did they look at? Well, they looked at 18-year-olds up to 75 and included 75-year-olds.
Yeah.
And none of the previous trials really did that and that's in a double-blind placebo-controlled manner. They may have done it off-label, or they may have looked at it in an open-label phase. That's important because age-related changes can impact the longevity or the efficacy of the drug. in terms of outcome. The second was that their USP would be, for me, that without changing the dose, you would get significant positive efficacious outcome in male patients. So we know that they have a higher muscle mass in the glabella complex in particular. And with that, you would expect a shorter duration of action, and that wasn't seen.
Right.
So that, coupled with the fact that it is the number one selling neurotoxin in South Korea, which is I'd say the forerunner of innovation in the aesthetic field globally. They've used it in other areas, for example, masseteric reduction, which they have more of a problem of in the South Korean, South Asian population. Hypertrophy of the calves, reducing that, or even shoulders.
Yeah.
So there's that, and the fact that it works is great for both an aesthetic practice perspective, but also medical.
Right. So it's been around for a long time, but obviously fairly new here in Australia. I certainly hadn't heard of it before, and I've been in the industry for close to 20 years. So I guess a lot of people might be wondering, what can you tell us about Hugel as a company? I mean, you mentioned that they've got amazing quality control and quality assurance, but it'd be interesting to know from your perspective, who is the company, what do they stand for, and what do consumers and providers need to know about the company?
So Hugel are a global biopharmaceutical company. They've had over 20 plus clinical trials on aesthetic neurotoxin analysis. They are the leading brand with Botulax in South Korea. As we mentioned, Letibotulinum has been around for over 13, 14 years with over 25 million vials produced. Within their global directorship as a non-executive director, they have as chairman Brett Saunders. So he was the former CEO of Allergan. I mean, he's just incredible as an innovator and leader in his field. So they have some of the best corporate people there, but they also have fundamentally a high level of quality control and manufacturing with multiple manufacturing plants globally. So they're not just sort of taking a license off of an external manufacturer. They manufacture and put their name where it matters. So that to me is very important. They are also they also have an arm, Hugel Aesthetics, in North America, Australia, and soon to be in New Zealand if it's not already there. And they are led so ably and well by James Hartman, who again has extensive experience within the aesthetic industry and is a true innovator in his own right, with the likes of Bob Bennett and others. So you've got people there throughout their expansion globally, not only of top brands which have long-standing clinical evidence behind them, but people, both corporate and at the sales level, that really feel passionately about what they do. For me, as a practitioner, I want any product to be able to go back to the manufacturers or the producers and be accountable, and to provide me with support or my patients with support. And they do that in such quantities that I get so reassured when I move forward. And similarly, they have a collaboration with Chroma Pharma. So Chroma Pharma are one of the biggest producers of hyaluronic acid globally. They've made tens of millions of syringes, and they are a family-owned business based in Austria, in Vienna, the Prince family. And I have to say, every interaction I've had with them, they are absolutely fantastic people to work with. They have such integrity that even when I remember when a patient had an adverse event from somebody else's product, but the patient landed in one of their KOL's clinics, they were still prepared to help them and find out what had happened to them. And you don't see that often.
Yeah.
So for me, it's at every stage there is that reassurance and quality and support that we all need.
Fantastic. So for the injectors who haven't played with Letybo yet, they haven't seen it, how does it come? You mentioned Botulax and Letybo come in different units. What does the vial look like? And what's the preparation? What does it look like?
So it's freeze-dried. It is lyophilized, so you get a white powder. It can come, in the UK, we have a 50-unit vial. In Australia, it's a 100-unit vial. It's reconstituted in using normal saline. You would reconstitute 100 units with 2.5 mils of normal saline. It has a shelf life, non-reconstituted, of about 36 months if kept at 2 to 8 degrees. Once reconstituted, it should be used within 24 hours. When you use it, so for every 0.1 mil of your syringe when drawing up, you would be delivering 4 units.
Yeah.
So if you think about the glabella complex, so you've got deep injections and proceras and the depressor supercilii, medial corrugators, you would be putting in 4 units in each of those. So that's 3 injections. And then more laterally, on the, some would say the lateral corrugators, or one would say the medial fibers in the midpoint of the orbicularis oculi superiorly, which is a bit of a mouthful. You would be injecting more superficially, and again, using 4 units. So in total, in the glabella complex, 5 injections, 4 units per injection. That's 0.1 per injection point. And that's on-label use.
I was going to say, so that's kind of useful or relevant. I don't know if it was designed specifically to do this, but the original, Botox trials had a 5-point glabella using the same dose. So it gives you an equivalence or a currency to sort of understand how it compares.
Yeah, I mean, we can go on and discuss conversions, and I could talk to you about it for ages, and I won't want to bore the audience, but one of the ways that you could do it clinically is by doing head-to-head non-inferiority studies. So there have been a number of non-inferiority studies conducted from as early as 2014 through to 2022 by Kim and then Muller et al. Respectively, looking at the comparison between Letibotulinum toxin and onabotulinum toxin. So that's totaling about 700 patients in a highly controlled, double-blind manner, where one arm is treated with ONA, another with Letybo. And what they found was at 4 weeks, 8 weeks, which are the general comparisons, on maximal Frau using a physician's assessment, where a meaningful result would be either 0 or 1, there was no statistical significance in either group. And when you looked at treatment emergent adverse events, again, there was no significant difference. So that would say that as a dose comparison clinically, they're equivalent.
So just to clarify, you're talking, I'm not familiar with all the different
Botox and Letybo.
Botox and Letybo, right. I'm just...
Okay.
Well, sorry.
I did notice in that paper, and I don't want to misquote this, you'll know the paper better than I do, but the responder rate was something I found unusual, but maybe it's common in all of the toxins, was about 76% at 4 weeks. So that sort of implies that 23% or so didn't get a response at 4 weeks.
Yeah, no, you've got to look at that very carefully. So that's a composite score.
Mm-hmm.
So the FDA, unlike the European Union and potentially the TGA, they look at it differently. So the FDA want a composite score that's the investigator and the subject scoring what they thought was a 2-point difference.
Right, okay.
So it has to be a 2-point difference to be meaningful for the regulator versus placebo.
Yes.
In the European Union, they want a 2-point difference, but it's only the investigator that's scored.
Okay.
So when you see a composite score of 70, 65, 66%, and you start comparing composite scores of other toxins, it's as good, if not better. So
that's really interesting.
That's the best way of looking at it, and that's a 2-point. But if you look at a 1-point score, you're looking at ranges of 95% plus.
Okay, fair. You touched on manufacturing, but if we could just sort of talk about it, because I did understand that maybe I've got this wrong again, but they changed from vacuum dried to freeze dried. Is that correct? And why did they do that?
Yeah, so freeze dried. So let's think about what the meaning first of freeze dried and vacuum dried is. So let's take, for example, freeze dried. So unlike a vacuum dried, there is a freezing process. That's the first thing. So think of a solid block of ice. If you keep the temperature either constant or low, so between -5 and -35, but you vary the pressure, okay, the vacuum, and go from between 100 to 100 pascals, you can actually change the solid block without going to liquid phase into vapor. Yeah. So that's sublimation. Okay, that's a freeze drying process. Okay, why is a freeze drying process used? It maintains the integrity of the protein far better than a vacuum dry process. Because what a vacuum dry process would be is the solid block without freezing would go into liquid. There's no sublimation phase. Mm-hmm. And the biggest variable there is heat. So you're applying heat. Right. And that can range from 30 to as much as 80 degrees, depending on the manufacturer. So there is this situation that there will be a slight change in the structure of the protein from its origin. And freeze drying, based on GMP manufacturing protocols, seems to have a greater level of stability.
So for the average injector out there that's had this product arrive in their clinics recently and they've got the prospect of recommending which toxin they're going to use for their patient, a lot of them are going to want to know, what is the practical difference? What is it that they need to know in terms of how they educate their patients on it? Patients are going to ask, why would I try this new product? This has been working for me really well. So keen to get your insights on what the sort of practical differences are and sort of the best way to communicate it to patients, because it has sort of taken the industry here by storm, because it is seemingly the most easy conversion from what is the gold standard here or the most used product, which is Botox, and providing people with an alternative.
I think the most important aspect that I would give advice to any clinician looking at this is, firstly, with your patient in front of you, are these patients toxin naive or not? So if they are toxin naive, it's a straight conversion going into Letybo, pretty straightforward. Broader range, age range, no sort of confusion on that. And on top of it, you can treat male patients and the older patients. So that makes it very easy for the practitioner when they're investing in buying their neurotoxin. And generally, they're buying in bulk to maximize the price point, unfortunately, but that is the way that the suppliers work. If you are looking at a patient who is already well established with neurotoxin, such as Inco or Ona, so botulinum or Botox, again, simple conversion straight away. When we look at patients that have used Ona-botulinum, generally those patients are being treated with not 125, but usually 150 Spaywood units or more. You have to be mindful that if you're trying to compare, and I'm talking about 3 areas of treatment versus just the glabella complex, so some off-label work, you're using a higher dose of this.
I think you meant Abo, not Ono, so Dysport.
Yeah, Abo, sorry, yeah. So Abo versus Letybo, you're using a slightly higher amount of neurotoxin in terms of units. So you've got to be mindful of that when you are maybe converting patients over. But what I found when treating patients. And remember, we talked about the manufacturing process being slightly different. That can impact not just the conformational state of the protein, but it can also affect the charge very slightly. And that needs to be taken into consideration. Now, you may say, well, why do I need to fuss about that? Well, sometimes you can get a better result if you try to just look a bit further and not sit back thinking, well, I'll just do what I always do, which is fair enough, one's choice. So when I've used it for off-label use, I use a slightly different dosing pattern for the forehead compared to what I was using with Ona or with Able. And that gives me a beautiful result, long-lasting, with no brow drop. Sometimes with Able, particularly in my patients in Northern Ireland, they have quite thin frontalis muscles. They are quite sensitive to a brow drop. So it makes it more easier for me as a practitioner. For a beginner or somebody who is coming through the ranks and getting more experience, it's more forgiving, therefore, for them. For someone who's very experienced, because they've got, I would explain to them, you've got high levels of predictability. They can be far, far more expansive when they're doing more intricate forms of toxin treatment, when you've got to deal with levels of asymmetry or particularly difficult frontalis to treat. And we do get patients like that. So I'd say Letybo is very forgiving as a neurotoxin. I've been using it for over a year and a quarter, year and a half now in the UK. I use it both on label and off label. And I can confidently say I've had no issues. I've changed the frontalis pattern, and Hugel Aesthetics are aware of what I've done and some of the information I've passed on. If it can help practitioners, absolutely, that's what we're here to do. And that's going to help their outcome for their patients and ultimately get their patients coming back and knocking on the door and looking at other treatments, because fundamentally, botulinum toxin is your bedrock for your aesthetic practice. If you have good, reproducible, safe results, it helps you to build from that. And that's been shown. I mean, I was looking at an analysis in Australia in 2020 to 2021. The annual revenue was about 2.98 billion Australian dollars, with the majority from at least half, about 57%, due to neurotoxin use. And then the second being using hyaluronic acids, dermal fillers. Over the next 9-10 years, with a compound annual growth rate of at least 24-26%, you're going to see that 2.98 billion going to 22.8 billion Australian. So it's huge. And what this is also telling us is that more and more patients will want the treatment as a preventative measure, more than anything, but also looking at other areas to treat beyond just the standard 3 areas that we see on the face.
If I could wheel you back, you mentioned on-label, off-label. So I gather right now, at least in Australia, I don't know what it's like in UK and Europe, that it's on-label just for the glabella. But of course, you know, in our practices, we do, you know, a lot of off-label treatment with all of our toxins. So, you know, what did you mean by you've changed your approach to the frontalis? And maybe to give us context, what were you doing before with other toxins?
So with other toxins, I would follow the protocol published by Mark Nestor in the past from Los Angeles. If you look at your frontalis and you ask your patients to raise their eyebrows, you'll see that the lower half or lower 2/3 of the brow rises, and the upper third descends, leading to a line of convergence. So if you stay above, and that wasn't described in Mark's paper before, so I go by the line of conversions as my limiting point generally. Everything above that should be deep into
Yes.
frontalis. So what I do is I do an injection which is parallel to the depressor supercilii, medial corrugator, just distal to the frontal hairline. Again, I look at the movement, and then maybe it'll be a bit further lower than that. And then in parallel to that, alongside, I look at, call it the lateral corrugator or the medial fibers of the superior orbicularis oculi. And then I'll inject in line with that first injection, a second injection. And I'll use 2 units on either.
Okay.
Then at the midpoint, about a centimeter below, but above the line of convergence, I'll use 4 units. And so it's 2, 2, 4. And then I'll do the same on the opposite side of the midline. And it's perfect.
I mean, every forehead's different, strength and surface area, etc.
But that is a general sort of baseline pattern that I would use for patients. Of course, I would assess them. Sometimes you've got patients with a very large diastasis, so their aponeurosis is very wide, so you're going to have to look differently. Sometimes you've got patients with very, very strong frontalis muscles, which are constantly active. Again, very careful, otherwise you'll get an immediate brow drop. So you may just want to just put a single series above and nothing below. You may have a very low line of convergence, and then you would look at that. And then you can look at more superficial lines above the brow, and you may be wanting to do, as one would advise, a more superficial injection rather than the deeper injections more proximally to try and limit that. Some patients will want a specific shape of their brow, but this is just a general rule of thumb that you could apply and then take from.
Yeah. Just to reference, that line of convergence was in a paper by Sebastian Cotofana, and we did a podcast with him on that. So if you're interested, guys, go back to that one. The reason I'm drilling down on...
It's a great paper.
It is a good one.
It's a great paper.
The reason I'm drilling down on forehead is because, well, one, it's a difficult area to treat, just generally, but also... this is anecdote. Whenever a new product is released, and Letybo is the one we're talking about, you get injectors telling you all sorts of things of it worked amazingly, it didn't work, it's not lasting, it's lasting longer, it's quicker. They'll just tell you every parameter under the sun. And so it's almost like, well, what is real? And so I'm just curious to know, what was your learning curve? Because, you've obviously got that down pat now, but maybe you didn't at the start.
And then just to, maybe it'll be a follow-up question, but and what do you think causes all of these injectors to come up with all these varying reports of anecdotal sort of reports of differences in, as Jake was alluding to, how quickly it responded, not responding at all, wearing off quicker? Like, if the studies show that they're almost identical in terms of their efficacy, why do we get so much variance in anecdotal reporting?
Absolutely. Great question. If you look at who or the clinicians carrying out these studies, generally they're very, very experienced, but also they're in an extremely controlled environment during the administration of these items. If we look at colleagues and what they're using, I've seen a trend over the last few years of colleagues going from using diabetic syringes, for example, the BD microfine syringes. The problem with using that is once you've done 3 injections, it's blunt. So your depth penetration is going to be affected and variable. So that's the first thing, particularly when you're looking at higher density tissue. Number 2, they don't change the needle. They use the same needle, the 30 gauge needle. It gets blunt. Number 3, they have changed the needle to use a shorter needle, so a 30 gauge 4 millimeter or a 31 or 32 gauge 4 millimeter. The problem with that is, and to my own detriment, I used to notice that you'd get a bit of backsplash because your extrusion force would be such, and because it's such a tight bore, it would go in, but you would get some backsplash and leakage. So therefore, you're not getting all of your toxin. So what I would do is I would count and wait and then see. And now I've stopped doing that, and I've just gone back to the 30 gauge, 13 millimeter needle, far, far better, cleaner, straightforward, and it's the one that's used in all clinical trials. So why not just continue with that? Some will say, well, my patients find it a bit sore. Well, you can do different things to try and obviate that by distracting the patient, etc., or even just using a small cold pack over the area before you start your injection. It's not going to impact the efficacy of the toxin at all. And certainly don't use lidocaine because that can interfere with the toxin. And that's one of the biggest differences. Plus, poor integrity in the cold chain. So a number of my colleagues, they still have satellite clinics. So they will specifically use a neurotoxin which doesn't require a cold chain, such as botulinum or botulinum, and that's fine. But I'd say the main reason for all of this variability is changing dilutions. So they start to experiment with the type of dilution they use. Number two, some have swapped from normal saline to bacteriostatic. See, it's less painful. Yes, because of the pH, I get that. But sometimes it can be due to depth, poor understanding of the anatomy and the variability of the patient and their anatomy. Sometimes the patients will be resistant to toxin, and that's a fact. Sometimes it can be lot-to-lot variability. So poor quality assurance and quality control, and that's from the manufacturing side, though that's very infrequent, I have to say. But there's this growing trend, not of colleagues that I know, but of practitioners that I'm aware of, that they will buy neurotoxin off of the internet and not get it off prescription, which is highly dangerous. I remember Professor Andy Pickett, a good friend of mine, did an analysis looking at that and looking at the variability of the toxins that you purchase off the internet, and the variations quite stark, from no toxin to extreme levels of toxin that could be quite dangerous.
That's incredible.
Yeah, crazy. The placebo effect is not a phenomenon that's. I think it's what I'm trying to say is that it's not a controversial phenomenon. People know that it's a real thing, and when you're telling patients you're trying a new treatment on them, so you're saying the patients that are already familiar and have had tox treatments in the past, do you think there could be a factor there of this placebo effect affecting the actual reality of the outcome by patients believing it's not going to be effective, or if they perceive it's going to be cheaper or it's different, that could actually be causing a physiological difference in the outcome?
I think we call it nocebo, don't we?
Yeah.
Yeah, nocebo.
Yeah, nocebo, placebo.
Because placebo would be no treatment.
Yes. Yes.
Yeah, so nocebo. So there's it can be as high as 47% in clinical trials.
Wow. Jeez, that's massive.
Absolutely. Because if you start to look at data, and different patients will have different expectation levels. So some patients, and it's also the assessment. So when you assess, and a clear guidance, I'm sure all the practitioners listening will do this, is eyes open when you're looking at maximum levels of contraction, not eyes closed. But patients will look in the mirror, close their eyes, and contract like hell, and say, I didn't see an effect. Well, how can you see if there's no effect if your eyes closed? But secondly, when you ask them to keep their eyes open and do it, they say, oh yeah, there is an effect. Yeah. So there's that element as well. But no, there's definitely areas where placebo will impact, or no result will impact on clinical outcome, but they're few and far between.
I'll tell you, one of the biggest areas of where variance is probably likely, and you see it on Instagram. Yeah. You know, you watch injectors doing their thing, and I see it a lot in Australia. I don't know where it came from, but a lot of injectors do their toxin very flush, creating a bleb rather than going deep, like you said, Syed. So, you know, if you want a toxin to affect a muscle, you need to put it in the muscle, not skirting in the dermis. So I see that
Absolutely.
a lot.
I'll tell you, I was at an anatomy demonstration up in the Royal College of Surgeons in Edinburgh, run by some dear friends of mine, Jeff Downey and Mark Devlin. And what's very important is the depth and the depth of how you inject procerus, which is a deep muscle, and your medial corrugators is deep. You're virtually touching bone.
Yeah.
If you're treating the lateral canthus, I mean, it's literally a millimeter below the surface. So and in that context, you have to have a bleb. But if you're going above the line of convergence, it's got to be deep again. And as long as you're following that, and when you're starting to do more off-label work in the lower face, you've got to be sure of your anatomy. And then depth does matter, dose does matter. Some of my colleagues will reconstitute in a smaller volume because they're worried about the field of effect and spread. What I say to them is, if you're in the right plane and the right depth, there shouldn't be a problem. But there's some certain caveats that you can apply when injecting the masseter, for example. There, off-label, you actually have to have a longer needle than the 13 millimeter 30 gauge, because you want to be touching bone with the patient's muscles contracted, ask them to relax. And as you pull back, you'll be injecting retrogradely. So you're hitting deep, medial, and superficial fibers. If you don't do that, or you don't use a long enough needle and the injection technique is incorrect, then you'll get this pouch bulging of the deep fibers by the superficial fibers of the masseter. And I see that. There was a very good study by a group in Italy. I forget the lead author, but they looked at that, and this was very important. And they varied the injection protocol. And this is another thing that clinicians should look at: is what is the published evidence, and what do they feel comfortable with in clinical practice about trying to reduce and minimize no outcome results. And that would be looking at not just what they're using, their assessment, their injection technique, maybe their toxin. But some of my colleagues will just be very happy with one particular toxin. That's fine. But they will probably only conduct certain types of treatments. But then there will be others that will be far, far more expansive. For example, Sebastian Kotwana and Jeff were presenting some work on a paper that Sebastian had published regarding the use of toxin for the Nefertiti line. Mm. And many in Brazil are using this as a preempt before using HA fillers, because it can lift the face, as you might expect, because it's a depressor of the mid-face. And the way in which the muscle traverses, it goes right up into the cutaneous ligament superficially, right up to the zygoma in some patients. So by using that lower border, just a centimeter above the jawline, you can actually achieve a significant lift by neutralizing the platysma.
Yeah, guys, again, we covered that paper with our podcast with Sebastian, so listen to that one again. I really want to ask you a couple of sort of questions about how you do it, because you said, you've got preserved saline or normal saline, needle choice, and all the rest of it. Do you think there's any difference? I mean, I know pain is almost non-existent with preserved saline, but do you think there's any effect on our toxin? Do you think we need to be worried? Is it legit? What do you do in your practice?
So in my practice, I use normal saline. In the past, I was using bacteriostatic more so. And I made a mistake once when I was very, very junior, and I mixed with water to the detriment of the patient. They were in agony, and I said, what did I do wrong? Wow. And that's why I'm very, very careful of how I administer toxin. I'm happy with using normal saline. A lot of my colleagues will exclusively use bacteriostatic because they feel it's less painful for the patient. But once the patient understands, let's say if you're using it, if you've got a naive to toxin patient, using normal saline is fine. But if you've got somebody who's used or has had bacteriostatic being used, they can see the difference. So it's up to the practitioner to decide whether or not they want to change. But I will just use a very methodical approach. I always dilute my toxin, reconstitute it. I don't let anybody else do it. It's a prescription drug. It's my responsibility. I don't see why any clinician should give that responsibility to anybody else, particularly when they've signed the script. It's their responsibility. It doesn't take long. So I don't care how busy the clinic is, you should do that because the patient is there in your hands under your care. And therefore it's your responsibility all the way.
Don't feel so bad, Syed. I've seen it done accidentally with hypertonic saline before, so water's not so bad.
Hypertonic.
Yeah, they were for scleotherapy.
It was bad. It was bad, but anyway.
Maybe you're the person to ask this, but we talk about comparability, and 1 unit of Letybo is, at least according to the paper, equivalent to 1 unit of Botox. But is it as simple as that? Because we know that the products also have, different diffusion capacities and all the rest of it. So you're nodding your head in agreement, but can you explain why that's maybe a little bit simplistic?
Well, we need to go back to how they determine the LD50.
Yeah.
So the LD50, the dose that leads to mortality of 50% of the cohort of mice when doing a lot-to-lot assay on your product. The problem is when you start looking at the LD50 across the board from one manufacturer to the other, one, they can use different types of mice, BALB-C, CBA, Swiss, etc., etc. They can use different weights. So generally it's 18 to 20 grams, but they can be heavier, they can be lighter. They may have a mixed sex population when it should have a uniform one, female or male, not combined. When they determine when the chow is given to the mice, when they're assessing the LD50, what time of day, that can stress them, stress the poor thing. So all of these factors have to be taken into consideration. And the FDA, and I don't know if you're aware of this, when they look at lot-to-lot variation with neurotoxin, allow a variability of plus minus 25%.
Yeah, I saw that
so
in a
you
study.
can have a lot. Yeah, that's 50% of what a previous one was, or 125%. Or 75 versus 125. So you've got a variation there of 50%.
But I find that incredible because, you're making a neurotoxin under the strictest conditions in a highly regulated, secure lab. So how can it be so different? I've never quite understood that, but you're right. I've seen a paper that was presented at IMCAS last year, and we were all scratching our heads going, wow, so I thought I had 100 units, but actually I might have 75.
Yeah, you would have thought. And biologics. So traditional biologics can have a plus minus of 40%.
Wow.
So you get something at 60% versus 140%. That's basically double dose.
Yeah.
In reality. And this is why I think you can see in some cases, I'm not saying it all, such variability. What I do know is because of the stringent nature of their manufacturing, there is a very, very narrow window of difference in the lot-to-lot variability with Letybo.
Mm-hmm.
I do know that Allergan's main manufacturing at Westport in the Republic of Ireland, again, has very, very strict release batch criteria. And that's very important. But that's where your variability and your inability to compare Spaywood to Botox unit, to Letybo unit, to Inco, etc., etc. Coming from that assay. Then what they do is they look at something like a mouse hemidiaphragm, phrenic hemidiaphragm assay. And there's variability in that as well. And they're using an EMG action potential to determine when you can get full neutralization or not of the hemidiaphragm and paralysis. But again, that's subject to temperature, size, the observer, the injector, their technique. There's so many variations. That's why we need statistics always to look at the distribution and determine, well, let's try and get a narrow fit. But I think you're right. We need to be looking at the manufacturers and saying, look, you need to keep this very tight. And this may, at least in part, explain some of the variability that we see in patients.
To our knowledge, Letybo have only done trials so far on the glabellar complex region. Do you know if there's any trials that are in the pipeline or coming focusing on, say, crow's feet or any other areas?
So the amount of money that's required to do any clinical trial runs into many millions. Yeah. We know that. We know also that Botulax has been tried and tested in multiple areas beyond the glabellar complex, so lateral canthal and frontal line. I'm absolutely sure that following, and this will always happen before a major investment in a clinical trial is conducted, is a pilot study would be done before you embark on a major trial on crow's feet or the frontal lines. It will happen. When that will happen, I think will be subject to the market uptake of any toxin that's new to a major region, such as Australia or the United States. And then with that revenue stream created, I'm sure then that will lead to natural investment into further on-label use. I mean, you see that with Allergan, who have expanded their indication of use to the use of in chronic migraine and beyond. And it's good, and that's what we need. We need even off-label use to be factored into more on-label use in the future because it protects the clinician and the patient.
Can I ask, I know every patient is different and, different dosing, different patterns, etc. But if you could sort of give an arbitrary therapeutic dose for each area, can you give us a rough ballpark? Because this is, again, we've got Letybo here in Australia and everyone knows, it's around 20 for glabella because that's what the studies show for mild to severe lines. But what about frontalis, crow's feet, and maybe even off-label areas?
Yeah, so off-label use in frontalis, I would use around 16 to 18 units in frontalis. I use 20 units in the glabellar complex. I don't vary between male and female. Lateral canthus on either side, you're using between 9 and 12, so divided into three injection points. If you're treating the lower face, such as the depressor anguli oris, you'll be using 4 units a side. Mm-hmm. If you're doing something like a mesenteric reduction, so it's not true bruxism, so you're not having to inject the temporalis, I would be using between about, in divided doses, between the two sides, a total of between 60 and 70 units. Mm-hmm. If you're doing platysma, it depends on how large the platysma is. If you're treating the Nefertiti line, each injection point, I use 4 units generally. So there'd be 3, then the DAO, so 3 of 4, so that's 12, plus the DAO, that's another 4. So you've got a total of 16 on either side. You may wish to inject the mentalis if that's involved. If you're looking at platysma, each point I'd be injecting around 2 units per injection point in a very dense area of the platysma, 4. If I'm going right down to the collarbone, 2 per point. If you're injecting the nasalis, be 2 to 4. Mm-hmm. If you're doing the levator labii superioris alipinaceae, between 2 and 4 on either side. And you may want to divide that as a single or 2 injections, so 2 or 2 on either side. If you're doing a lip split, 1 unit on each point, just lateral to the philtrum, so a few millimeters lateral, and then sort of midpoint of the lip on the upper lip border. That's generally what I do if you're doing bunny lines, 4 units a side. But that probably covers most of what you need to be using the face for. If you're doing mentalis, if you have a very dappled texture to the chin, I would be using 3 injection points if it's wide, and you'd be doing 2 units each. so midpoint and either side, and you'd be doing that superficially. So, and if you're trying to reduce intrinsic mentalis activity deeper, then you can use 4 units and put that in the midpoint.
Well, that was really interesting because everything that you said, apart from Frontalis, is, I would imagine, what every injector in Australia is broadly doing. But I think everyone's underdosing Frontalis. This is completely anecdotal, but if I asked 100 injectors in Australia who I knew, what's your rough dose in a forehead, they would say between 8 to 10, maybe 12, but not 16, 18. And that is the area that I believe patients are seeing that's sometimes underdosed and coming back saying, hey, it didn't work. So that's been really, really valuable. I mean, are you using similar doses?
And remember, you've got a hot climate, Jane. You've got a hot climate out there. So with that, generally toxin doesn't last as long. And it was the eminent Professor Goodman who said that on his analysis, he wrote a paper on premature aging of women in Australia versus women in the West. And it's frightening to learn, because of the level of sun damage, that they could prematurely age by about 20 years plus.
Yeah.
Over their age-related counterparts.
Yeah, we definitely see that. But I guess the counter argument to that is the crow's feet seem fine, glabella seems fine, but Frontalis, it's where the patient perceives it as not working. Maybe it did, maybe it didn't, or maybe it just toned it down.
Yeah.
And you get, understandably a defensive injector saying, I don't like this product. It's not working for me. I'm going back to what I used to use. So I just think it's a dose issue. And I'm not saying every patient needs 18 units or 16 units, but don't be scared to sort of do something different. If it's not working, maybe it's not the product that 25 million vials of Letybo were sold by.
Yeah. I think injectors in general are very defensive in that area and tend to underdose. May I ask, Professor, what products do you use in your clinical practice? Do you have a mixed bag with a whole assortment of weapons that you pull out? And if so, what are your determining factors on which ones you use when?
Are you saying which toxins?
Which toxins? Yes, neurotoxins.
Yeah, neurotoxins. So my mainstay neurotoxin, my go-to is Letybo. Then it would be Nocebo or Botulinum. Then it would be botulinum, so Botox. And in some patients, I'll use Dysport or Azalor. Mm-hmm. So that would be my mainstay. And what choices? Generally, some patients will specifically request a particular one. If I've got patients who are new to toxins, naive, Letybo straight away. If I'm converting them, if they've used previously Inco or Botox, I put them on Letybo. Or in some cases, if they prefer to stick with Letybo or Botulinum, I will use that. So I have that capacity to vary, but my mainstay would be Letybo, then it would be Ona and Botulinum, and then lastly Dysport or Azalor. And I will say this: if I'm doing a hyperhidrosis treatment, for example, my 2 that I would generally move towards would either be Letybo or Dysport. If I'm doing something like a mesenteric reduction, I would use something like Ona Botulinum generally. And then Letybo, because more of the clinical trial data is based on Ona Botulinum. So I feel a bit more comfortable in that sense.
But it was also because you're sort of looking at the property of that toxin. So, we typically think that Dysport tends to have a greater spread. So it makes sense if you can do hyperhidrosis to maybe choose that toxin, or is that not what you're thinking?
Yeah, I think it's based, I see what you're saying, Jake, but it's mainly based on some of the clinical trial data. When you talk about spread, you have to be very, very careful, because Doris Hexel, who published a lot of the work, showed that the spread wasn't due to complexing protein differences. It was due to primarily concentration.
Right.
And if you look at the field paper, when they compare the amount of toxin per vial, and you look at a standard treatment such as an upper limb dystonia, lower limb dystonia, or glabella complex treatment, the amount of neurotoxin that you are injecting within 10 Spaywood units, for example, is more than the equivalent, say, 2.5 times less of botulinum Botox. But when you look at the amount of neurotoxins, so that's in nanograms, there's a higher level on different. So I think that probably will explain why there may be a greater level of spread, as you say, as opposed to any other reason.
Okay.
Also, I'm more inclined to look at toxins which I can control and reconstitute myself. So I'm fully in control of it, particularly, and that's where I think Alluvians, which is already a standard concentration, when using it in certain areas where you want to maybe use a more hyperdiluted situation, then you're going to have to go off label anyway. So I just choose the latter because I'm used to the conversion rates, etc., that I've used in the past.
Yeah, such a good point. You mentioned complexing proteins, and we haven't really spoken about the protein load with Letybo versus some of the other toxins. And you sort of said right at the start, I don't know if we were off camera, but you were talking about, the rates of resistance or lack of rates of resistance. So what is the, clinical trials? Do they show that Letybo's the same as onobotulinum toxin, or would you choose Xeomin in certain patients? Just what's your take on resistance, I guess, is my question.
Yeah, so when you're looking at complexing proteins, so both Letybo, ONA, so Botox, Dysport, ABO, all have complexing proteins. Okay, but they differ between them. They're not the same proportions, orientation, but you have what are called non-toxin associated proteins and hemagglutinins. So they, in nature, they are used by the Clostridium bacillus to protect it from gastric acid digestion and breakdown. In the manufacturing process, whether you look at different forms of complexing protein-associated neurotoxins, many of them are like for like, with the exception of Inco, which is devoid of it. But what Inco uses is human serum albumin in a larger quantity, about 1 milligram, versus 0.25 milligrams in the other types. Human serum albumin itself can bring about antibodies, so you can get sensitized to that. What is very important to understand also in human serum albumin is that it's not recombinantly made. It's from pooled blood.
Yeah.
So you have an issue there. So for me, that's an important one that is like the elephant in the room and nobody ever talks about. But in terms of neutralizing antibodies with the study with Letybo, when you measure neutralizing antibodies, you look at different ways of doing it. One is with an enzyme-linked immunosorbent assay, which isn't the most accurate way of doing it. Another one is looking at protein-protein interaction, so antibody binding to the toxin protein. And that's the gold standard in protein-protein interaction studies. And they used what's called the plasma surface resonance system biform. So it releases a tiny electrical activity when they bind, and it is so finite. You can look at the most infinitesimal interactions, and they found no neutralizing antibodies at all. Phrenic, we've talked about the phrenic hemidiaphragm model. They can use that to test for neutralizing antibodies in sera. And as I said, the ELISA study. But when you look at studies by Fabry and others, where they looked at 8,500 patients, and they looked at the number of neutralizing antibodies evident, what was the frequency? It was so small, but it generally was found in patients who had long-term high-dose neurotoxin being used from an early age, where their immune systems were maturing, as it were. They are more likely to developing neutralizing antibodies. So those are the patients with dystonias, cerebral palsy, etc., etc. In the aesthetic arena, it's hardly seen at all. Though there have been papers comparing and contrasting. I remember a paper from, it was actually a Merck's sponsored paper, where they looked at, I can't remember the numbers, I think it was 355 in each group, and they looked at complexing protein as one group versus non-complexing protein. But what they did was interesting. They lumped everybody together. So patients were getting ONA, some were getting ABO. That's not particularly scientific. You need to keep them separate because they could get sensitized to other things apart from that. Because it wasn't statistically significant when they kept them separate, but when they pulled the data, there was some level of significance. But the report was such that it would mean that about 20%, if not 15% of all of our patients would not have any clinical effect. Now, that's not what we see in clinical practice. There have been millions and millions and millions and millions of treatments, and the frequency of neutralizing antibodies reported are minimal.
Yeah.
And if you go into an audience in a major conference and ask them, put your hand up, how many have you seen in your clinical practice? You'll get a handful. Why is that? And the reason is, if you have neutralizing antibodies, it doesn't necessarily mean you're going to have no clinical effect, because that's what the studies were showing. 50% of patients that had no neutralizing antibodies that didn't have a clinical effect had it for another reason. What was that reason? Is it genetic polymorphisms? Is it the fact that the patients have been on antibiotics and not explained themselves? Could it be poor injection technique? As we know, that can have a big variation. Could it be a problem with the cold chain? Could it be this lot-to-lot variation that we've described? There's so many scenarios. It's too oversimplistic to look at it like that, because if that was the case, then onabotulinum wouldn't be holding 80% of the toxin market as we speak, because that has complexing proteins in it, which we all know.
So bottom line, very rare, and there's no real issue.
Yeah,
perfect.
And you can take about half of those studies by the way in which they were conducted, the temperature of the room, the ELISA kit. I've done all of those sort of studies as a postdoc fellow in the States, and I know how the variability arises. So one day you can get an experiment that works, another one it doesn't work, and then it was very sad to see. I remember a colleague, he was a vet, and he repeated this particular experiment 18 times over 1 year and got no result. And it wasn't until he presented the paper that we all started looking, and we thought, oh gosh. But he's using that particular antibody with this type of cephalose to just bind and pull down. It's the wrong one. And he was never told. And that's why it never worked.
Oh, gosh. So a lot of injectors will be listening to this and thinking, this sounds great. I might want to try Letybo. This is all very reassuring that it's a quality product. But a lot of them will be facing the challenge of, how do you explain it to your patients? Or how do you, I don't want to use the word convince, but educate them on potentially why this might be a toxin that they might want to try or convert to. So do you have any tips for how to do this? How did you do it with your patients?
Going to just add to David's point. I mean, you have a patient who you might have seen a number of times. Of course, they're not toxin naive, so maybe it's a little bit of a different conversation. But really, from the patient's perspective, they're like, well, I've been happy numerous times. Why would I want to, even if you're saying this thing is good? So I'm just curious to know what you said to your patients, when you first started with Letybo.
So the first thing that I specifically looked at was, is this patient, or has this patient been prone to a brow drop? So that's one of the things that I quickly say, right, most likely not going to give you that. I can't guarantee it, but I think there's a high likelihood that wouldn't happen. And that's a big seller, because a lot of them hate that. And for 3 months, they're not happy. And they may not come back. secondly, I look at whether it's a male or female patient. And if it's a male patient that's had a particular toxin, I explain to them that this has been evidence-based, it's on label, that may or may not convince them, or may sort of trigger them to potentially try it. The other is when you're looking at a broad age range. So particularly when I'm looking at older female patients, it's something that I say, well, this is on label. It's been tested rigorously. Whilst we've used off-label use in the past, this may suit you better. And I think it's worth trying. And I leave it to the patient to make the decision at the end of the day. I don't try to push them into one or the other. I give them all the facts and then allow them to make an educated decision and an informed decision based on their consent. And if they choose to go one way or the other, that's fine. But what often happens that I find is that patients talk and they've said, well, I've had that and I really liked it. And then you'll find that their friend or colleague will come back and say, look, XYZ had this. I think I'll try. And that's what generally has happened. And the number that are using it has expanded over time.
I mean this in the least controversial way, because I'm the same as you. I'm a trainer, key opinion leader, whatever you want to call me. But do you declare to your patient, do you say, look, hands up, there may be some inherent bias here because I'm talking for the company, I'm paid by the company. However, in my experience, I'm really happy so far. Do you ever talk about that? Absolutely.
Always tell them. So fortunately, I've been able to speak for a number of companies. And I was speaking to, I won't name her, but a colleague within Allergan who was fantastic. And she said to me, I actually want to see key opinion leaders who look at different products.
Yep.
For me, they're more experienced. And at the end of the day, their opinion will be more valuable to me than otherwise. And I think patients also view that. And I will always say, I will rigorously examine whatever I'm using. And if it's not good enough, it won't be put in front of you as a possible suggestion anyway.
Yeah. That's totally reasonable. Here in Australia, Letybo has launched, a few months ago now? Yeah. It's certainly enticing in terms of its cost, for the injector to buy. So is that the same in the UK? I don't know if you can give us a cost or a price.
Yeah, depending on which pharmacy it's purchased from and the degree of your bulk order, it can range about £54 per vial.
Wow, that's cheap.
50-unit vial. And that compares well with some of the other toxins, which would be in the mid-60 or £70 or £72 mark.
Right.
So there's quite a difference there. So as much as 40%. So that over time, some of my colleagues are mainly doing neurotoxins. So when you start to add up the numbers, some of them can avoid having to inject for a whole day in a month because of that, without compromising the impact on their patients.
Yeah.
So it gives them more time to spend with their family, do other things. So in terms of giving you a bit more flexibility, I think it's a good thing.
Yeah. And do you charge your patients the same price for all your toxins, or is it varied depending on which ones?
Yeah.
Yep, same.
Irrespective of whichever toxin, we just keep it standard prices. I think it's easier to follow.
Yeah.
That's actually a really good question because, again, I don't know why, but a lot of Australian injectors are sort of dabbling, it's cheaper. Maybe I make it cheaper to sort of create a point of difference, and this is why I'm offering you a new toxin to my patients.
Yeah. I might just, before you jump in, Professor, I might just add something from a business perspective. The people that do that, you just need to be aware of the rod that you're continuing to make for your own back. We've had discussions on the podcast infinite times around the challenge of not wanting to commoditize what we do or having patients perceive they're paying for a product as opposed to a service and your skill. So as soon as you start going down that path, which is a very difficult one to walk back from, you do put yourself in a very compromised position in terms of almost degrading your skill because you're charging patient different prices for what should be the same outcome with a different product. So
Agreed.
Sorry, Professor, you continue. Yes.
Yeah, no, I agree with you. That's why I keep the price the same, because there's a full consultation process, there's follow-ups, they're all part and parcel. And sometimes you're going to spend a lot of time with your patient, sometimes only a matter of moments. You have to review their photographs, take the photo, all of that. And they may wish to speak to you either by phone, the web, or in attendance if there's an issue or whatever it may mean. They may need an additional tweak. All of that is incorporated into the price. We don't charge anything in addition beyond that. So it's a service, as you rightly put, and it encompasses all aspects.
Yeah. And maybe just one final analogy just to further drive home that point if it hasn't already sunk in. If you buy a piece of art, you're not paying the artist for the type of paint they're using. You're paying them for the beauty of what they've created or their artistic skill. And I think we should be, as someone that's not a practitioner but has a lot of admiration for people like yourselves that do this, is that we should be valuing the skill and the artistic integrity of what it is that you do.
I demand you call me Picasso from now on.
I'll call you something else.
Actually, Picasso's not good if we're thinking of faces, but anyway, bad analogy. Yeah. One last thing, I know this is sort of a bit of a quirk of being in Australia, but from the UK, and I've seen both markets, and just curious to get your take on it, having looked at all the studies and worked for different companies. But in the UK, you guys charge per area generally. Here in Australia, we charge per unit. And, Michael Caine had his own thoughts. Other practitioners got their own thoughts. I've got my own thoughts. But what do you do in your practice? But also, what do you think of like the converse, the other argument?
I think it's what you're used to and what your patients are used to. We traditionally and have always done per area. It's straightforward, simple. Charging per unit, yes, you can do that. I don't see an issue with it, though it's quite time consuming when you're going through it. And patients will say, well, last time you did this and this time you've used a few more units. Why did you do that? How much more does that cost me? And it can create a lot more confusion. And it is much more time consuming to assess and equate and cost that way, I think. If you're doing a specific procedure, whatever it might be, lower face neurotoxin, platysma, nephritis, what it might be, you should know roughly what sort of concentration and amount of toxin you're going to be using anyway. And that should be reflected in the price that you would be charging. If you're going to need to use more for whatever reason, you should explain that to the patient and say, this is what we would do as standard. However, because of X, Y, Z, I'm going to need to use more toxin, and there would be this additional cost. That I can see as a way of introducing part of that. Though from the starting point, we always use an area or a treatment that we're going to do and cost it accordingly and know approximately the range of toxin that we would be using.
I'll tell you why we do it in units in Australia, because it's bloody expensive. The product is genuine. No, it's true, because I can tell you the prices, but it's much more valuable per unit, and therefore we kind of have to know how much is going in to justify pricing and what we're selling. Whereas, £54, I think you said, for a vial of Letybo.
Yeah, for 50 units. Yeah.
Who gives a crap if you add an extra 4 or -2? It kind of becomes a bit silly.
Yeah, I agree. I don't know how much it costs in your neck of the woods.
It's about 4 times that.
4 times that.
Maybe even 5.
So I can understand why you would do that, for sure.
It's like gold. Yeah.
That would make economic sense to check the units.
Yeah, absolutely. When you spill a little bit, it's like you've completely ruined your day.
Yeah, I know. Or that bubble gets into the syringe and you're trying to flick it out, And then, oh gosh, there's a few drops.
Oh, there's $5 on the floor. Oh, damn. Exactly. Well, that's been a fascinating conversation, Syed. We really appreciate your time and your wisdom. And I've learned a lot, actually. So thank you again. I would love to, maybe for our patrons, if you could maybe draw us the forehead pattern that you're describing, maybe on one of your patients there, your wife or yourself, whoever, just so we get some idea of your pattern and what you were describing. I think that'd be really useful.
Yeah, and just flick it through to us and we'll post it to our private Patreon group, which contains about 230 very keen practitioners from around the world. And so
eager for more.
Happy to do that.
That'd be great.
That'd be fantastic.
Happy to do that.
Have you been to Australia before? Are you coming? Are you going to be at any of our events?
Yeah, I was there. I helped launch Letybo in Australia, in Melbourne and Perth. It was a really energy sapping sort of commute there. I got pretty bad jet lag. It's a shame I didn't get to see enough of Melbourne. Perth was beautiful with the weather. Melbourne had a few storms. I really wanted to see more, but I was exhausted.
Yeah,
I had to give about 6-7 lectures. But I'd love to come again. I've given a few webinars, and I've got some very good Australian friends here. And in Australia themselves. So, hopefully soon. But I'll gear myself up for that long haul.
Well, you've got two more.
Commute.
You've got 2 more friends here now, so you'll have to come to Sydney, because going to Australia without coming to Sydney is like going to the UK without going to London. So you have to come.
I'll be there. I hear the weather is fabulous
most of the time.
and you've got a lovely coastline. It's a few more hours further east from Melbourne. So
it's about an hour and a half flight. It's not too bad.
Well, when you're jet lagged to crap, it doesn't matter. 2 more hours, it's all good.
Yeah. No, you'll love it.
Fantastic. Well, thank you again, Syed. We really appreciate it. And take care.
Yeah, lovely to meet you.
Take care, guys.
See you later. Thank you.
Bye-bye.
For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our IA Patreon platform for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.